I'm Dr. Tom. So my talk today is on the secrets no one told you about obesity. I'd like to first ask the question, what percentage of patients would you consider that you see on a daily basis who is overweight about the age of 25? So I'll give you a few categories. Less than 10%, 10 to 30, 30 to 50, or more than 50? Okay, that's overwhelmingly high percentage. And if you now consider how many patients you're just even seeing in a year, so it's a significant portion, it's a significant problem. And my appeal for this talk is that we stop seeing it as an intractable problem. We often have a negative, we see a problem and we almost become negative, be it ESCOM or water crisis or whatever it is. We tend to, as society and even as doctors now, consider some problems not solvable. And I'm hoping that at least we start thinking that maybe there is a solution in some cases. It might be a difficult problem, but there can be progress. So that's where I wanted to start the talk. So the definition of obesity, as you can see, is quite a complicated definition. I'm not really going to read it at this stage, but you can see it's a multifactorial, chronic relapsing multifactorial neurobehavioral disease, an increased body fat or most adipose tissue dysfunction, abnormal fat mass causes physical force as a result, etc. Blah, blah, blah. It's an incredibly difficult definition, and I hope by the end of this talk, I review the slide again, and you understand what the definition and the elements of the definition mean, so that when you see a patient, you see it as a disease and what elements it is part of it. So why do we get obesity? In terms of my talk, I'm really trying to keep it to the main ideas behind the concept. And there are mainly three things that we think about when we think about obesity. The environment is one, the genetics, and then energy balance dysfunction. So the environment has dramatically changed. Where you look at in the past, where just looking at the food that we used, we lived in if you look at our ancestors, it was a time of scarcity, where food was difficult to come across. Large percentage of the population were involved in manual work, farming, versus we actually live in quite an abundant time. Obviously the system is, maybe there's inequalities in the system, but if you just think of where we stand now and take a 2-kilometer radius of this place, you probably see that there's probably 20 restaurants. And that's the reality. And versus in the past, it really was a struggle. And so in terms of our body systems, we've actually been designed to survive on scarcity. And you'll see that the concept that I really want to keep pushing is that we probably haven't understood that we have to evolve for this abundance, especially in terms of food because of the improved agricultural availability. The work we do, there is less doing manual work. Even our social hobbies have changed. If you look at the general population, they'll rather be watching something on their laptop or Netflix or Showmax or spending time on the internet. So it's completely, our environment is changing. And we need to become aware of this because the way we tackle these problems is changing. And for me, one of the scariest articles I read recently was on night wakings in toddlers, where toddlers are using tablets and then disrupting their sleep patterns completely. And this is a real, we've all seen this, where I've even seen it in my own home, where child is crying and the first thing is, here's a phone or here's a tablet. And we're not realizing how it's disrupting our basic simple things that needs to be controlled. And you'll see that in terms of obesity, it's the basics that matter. What you eat, what you exercise, how you sleep, what activities you do, how your mental well-being is. So the environment has changed. And so I want you to just understand that our patients are often unaware of this as well, and we need to educate them about it. Obviously, we live in a similar urban area, but not all of us are overweight, and not all of us are obese. So there is an element of genetics, and this has obviously been proven in twin studies and forced children who became adopted. And we've obviously identified a few rare monogenic mutations that cause things like leptin deficiency. But these rare mutations are quite very insignificant almost, because they don't contribute more to the major part of the genetic element. The major part of genetics that we see in obesity is epigenetics. The gene expression without necessarily altering the genetic code. So how our environment and the chemicals that we're putting into our bodies, the specific foods, the reactions that cause different genes to be expressed, results in a threshold that increases our weight. And that interaction between our environment and our genetics plays a far more important role than pure a mutation or a certain code. They've actually identified more than 300 loci that are involved in the weight. And so it's a very finely tuned process. And so what this environment and our genetics eventually leads to an energy balance dysregulation. And the last aspect of this is the neurobehavioral effect. How the our behavior in this environment with our genetics plays a role in causing our weight changes. And so just to refresh you guys' knowledge on just the appetite, simple hunger, appetite. So when you feel hungry, usually your stomach and tissue, the adrenals start releasing ghrelin, cortisol. You can see why stress is probably playing, you start gaining weight. A lot of people start gaining weight when they become stressed and they start eating more. It's just because that's the normal mechanism of increasing appetite. And these act on secondary neurotransmitters, nerves in the brain, causing central stimulation of the hypothalamus and the arcuate nucleus, and causing us to increase our food. And once this has happened, then you get especially insulin, leptin, CCK, glucose, amino acids, the free fatty acids, all acting on the central inhibitors and suppressing this pathway. And therefore, then your appetite is suppressed. But then, as you can see, there's modulating factors. And the modulating factors is actually what I've just kind of described in terms of our environment. And one of the most important things is actually our prefrontal cortex and its functions for attention, memory, concentration, as well as, so that is another thing that it was quite interesting to see how technology, the use of, it'll be interesting to see how people are using WhatsApp and messaging, Facebook. It's going to affect the prefrontal cortex attention and increase this epidemic. The other aspects that modulate is obviously sleep, lack of sleep, excessive sleep, as well as the quality of sleep, which we often see in patients with breathing problems like sleep apnea. Then food. Obviously, the quantity of food matters. So if you decrease your food intake, it has a modulatory effect on the hypothalamus. And then specific foods. So they did a large study of 121,000 individuals and observed them for almost 20 years. And they saw the patients who are obviously eating the chips, the cool drinks, the processed meats, they're the ones who gain more weight than expected, versus people who are eating healthier fruits, vegetables, things we actually do know, but were the ones that didn't have that marked increase. So food, exercise as well. Physical activity is one of the few things that have brought down this endogenous adaptation to increasing our weight. So it's also one of the interesting things, which I'll touch on a bit later, is how a decrease in food intake actually affects this pathway, and why patients are relapsing and continuing to be chronic. The pathophysiological effects of what happens when you're obese is an incredibly complicated topic, and I can only really speak about the essence in this talk, I think. And I don't know how many of you know about this Japanese art, and basically most of the art is like this gray, black, I can't remember the exact word of what they call it, and they highlight a little bit of red or pink to just show the essence. And so hopefully in my talk, I'm just showing the essence of the pathophysiological effects of obesity. And there's mainly three things, and the first thing is mechanical stress. So if you can just imagine where anatomically fat is deposited, what effects could it cause? So intra-abdominally, it's going to cause an anatomical change, and therefore you're going to think about things like gastroesophageal reflux disease, leading to Barrett's esophagus, or and even esophageal adenocarcinoma. Mechanical load, we all know the patient comes with osteoarthritis, lower back pain, typical mechanical stress related to just the fat. Then pharyngeal soft tissue, the sleep apnea, pulmonary hypertension, leading to copulmonale. And then renal compression is something we might not think of as an anatomical thing, but the compression of the kidneys causes hypertension. And then the physiological effects. The physiological effects of the adipose tissue. We know now that it's not just fat. It's a tissue that produces cytokines. It's a tissue where macrophages come and settle, cause apoptosis. And there's mainly four major categories that I would like to highlight. The first is the pro-inflammatory cytokines. So the adipose tissue is producing these adipokines, which are pro-inflammatory, and so there's always a constant low-grade systemic inflammation occurring because of obesity. And this is due to the adipose dysfunction, and as the mass increases, this dysfunction worsens. And this leads to things like insulin resistance. It's contributing to many of the malignancies that we think about when we think about obesity. And then the things that we are hearing more and more now, non-alcoholic fatty liver disease, steatohepatitis, liver cirrhosis, and then obviously the things that we normally think about obese patients, the coronary artery disease, the heart problems, the strokes, the renal problems. And then the second aspect that I would like you to think about the physiological effects is the excessive lipids. And this is increased in free fatty acids, which also has a role in the pro-inflammatory state and causes increase in insulin resistance, as well as it also plays a role in liposomes that are excessive vacuolation, steatohepatitis, again leading to liver cirrhosis. And then you also, some of the things that we tend to not hear too much about is the lipid intermediates, which cause cellular dysfunction and apoptosis, which is becoming more, the serotypes and stuff, which are becoming more and more popular and more researched, which also have a role, maybe in playing a role in some malignancies that are suggested, but it's still very early. And then obviously the availability of steroid hormones, that's also playing a role. And then you can also think about just the dyslipidemia. the cholesterol leading to coronary artery disease, again, similar problems, heart disease, kidney disease, strokes. Other things that people often forget is that it causes increase in sympathetic activity and increased renin-angiotensin. And often you will see most of your obese patients struggle with hypertension. And it would be very interesting to you. I always find it interesting just looking at my patient's pulse rate. An obese patient walks in, the heart rate is usually about 90, at least. Because they've got this constant increase in sympathetic activity. Obviously, they've got to increase body mass as well, so the heart has to compensate, but there is this constant increased sympathetic activity going on, and obviously leads to problems later on. The other aspect that we often have seen is the psychological aspect. Most of these patients who are obese are more prone to mood disorders, anxiety disorders, depression. This is also a bi-directional problem. So if you've got mood disorders, anxiety, depression, you're more likely to become obese. One of the things that I wanted to highlight is that the medication, especially a lot of the antipsychotics, increase weight gain. So we need to be aware of the medication that we are using. How is it impacting on our patients' lives? Just to be aware, because even our diabetics, we need to decide, okay, let me go for the diabetic medication that's maybe assisting with weight loss. In terms of how do I modify this, and I think this is where it becomes very challenging. We know these things, and I just want to kind of make it so you're aware of it. Is mainly this behavioral therapy, counseling, but the essential idea that most of the literature is now trying to make clear is that you need to make your patient aware of the decisions that they're making. So we often like to, as doctors, tell our patient, eat this, drink this, follow this, and it's actually the wrong way to motivate these patients. There's a big aspect of motivational interviewing these patients, trying to tell them what do they think is wrong, how do they think they can change their dietary habits, how do they think they can increase their physical activity, versus us bombarding them and telling them what to do. It's obviously a difficult thing. It takes time and patience to listen to them, let them talk, but it's really the crucial element in terms of changing their neurobehavior. And that's a big aspect. How do we change that, making them personally aware of the situation? In terms of diets, I'm often asked which diet do I go? Do I go for Ornish diet? Do I go for Banting diet? Do I go for Atkins diet? There's so many diets that are available. But the essential idea is most of them are about decreasing the calorie intake. But the key aspect to understand is that it needs to be persistent and long-term. Patients, and you can't have a diet that takes 2 weeks and then recovers. Let me just go back to this drawing. When you decrease your food intake, what is actually being done in your body is that these are being suppressed dramatically, and these are increased dramatically. Just because of basically on thermodynamics, where you eat less and you exercise more, you lose weight, the patients will lose weight initially. But if they can't maintain that, they eventually gain weight, because this pathway is always being stimulated. And the interesting thing about that study that they did in terms of checking for these hormones is that they saw that these effects are even after 12 months. So, so us thinking that if a person can go on a 2-week diet and change their habits is not practical. Our endogenous adaptation takes time. And so that's why you need to decide on the dietary patterns, which are the different diet plans, that suit your patient that they can persist and adhere to. And this is taking into the backgrounds, the cultural perspective, what foods is available, etc. And educating them obviously on the word, really things that they must be avoiding. But it's really about getting a plan to work towards a long-term plan, because the endogenous adaptation that's going to happen takes time. Like I mentioned earlier, we designed for scarcity. And so you need to almost restrain yourself, especially in these diets, to work towards that goal. Exercise, I'm not talking too much about exercise, but in terms of exercise, there's again an initial weight loss. So often, most of the studies you'll see 30 minutes exercise, they lose the weight, but to maintain the weight, you kind of have to increase your weight exercise. So the studies show to maintain, it needs to be up to 60 minutes. And one of the things that we often tell our patients is 30 minutes, these are the guidelines, but I think we need to also think about it as a habit that the patient doesn't really want to do, and educating them on how they can start small, even if it's 2 minutes, or sometimes tell my patients, just walk for 2 minutes, get into that habit, get something going, and gradually build up. It's not a quick fix. We're really trying, obesity is about really building, working at our patient for a long time. And so it's exercise is a fundamental aspect. And then sleep. This is probably something that we neglect. Just simple sleep hygiene. So lack of sleep. Because there's more than enough evidence, and you all know that you're not refreshed like this little baby in the morning if you've got lack of sleep. And so therefore your decisions, your attention, your concentration, what choices you make, what you buy, how much you eat, whether you want to exercise or not, is all altered. And it's very simple to help with educating them on sleep hygiene. And it's a problem that's growing, where you talk to the patients, they say they have the phones with them, they have the tablets on their bedside, they don't switch off their lights, whatever it is, versus maybe in the past, like I know with my grandfather, he would like 10 o'clock switch off the light. The timing is important most. He actually used to pull the main switch. So all the technology kind of switches off. So it's really, it might be outdated knowledge, it feels outdated, but that timing and all those things actually matter in the quality of our sleep. And one of the things that we also see is the quality of sleep. Even though some of your patients, especially the ones who struggle with sleep apnea, will say, no, doctor, I'm exercising, I'm trying to exercise, I'm eating well, but the weight's not coming down. And that might be a sign that they have underlying sleep apnea. And this is Stop Bang is a screening tool that you can actually have a look at. And basically in the screening tool is basically S is for snoring, T is for tiredness, O is for observed apnea episodes, P is for hypertension, P is BMI above 30, age above 50, neck size of 41 centimeters for females, 43 centimeters for males, and gender is males, and then postmenopausal women, something that we often forget. And if you have 3 or more, you have about an 80% chance of having sleep apnea. And then if it's 5 or more, it's about 90%. So it's a quick screening tool. It's important to keep in mind. And the other presentations is also sometimes wheezes, adult wheezes. It's not always just diastolic dysfunction, heart failure. It could be a sign of sleep apnea. And then the drugs. drugs are just adjuvant at this stage. You need the lifestyle modifications with the drug. In terms of the different drugs, our appetite suppressors we're trying to avoid because there's been a lot of evidence over the past where they cause cardiac problems, hypertension, valve problems. Even though they have come up with newer agents, most of them are still amphetamine derived, and so you try to avoid them. Unfortunately, a lot of them are over-the-counter products already and still readily available for patients. Then orlistat is quite an effective drug. It's been approved, FDA approved, I think, since 1999. The problem is the side effects. It's not so expensive, relatively not expensive, but the side effects of steatorrhea, reflux disease makes it for certain patients not tolerable. And usually it's worth trying, and most of the depends on how well your patient will tolerate it. Anti-diabetic drugs, metformin is not really an anti-obesity drug because it doesn't cause more than 5% weight loss in 6 months, but it has been shown to cause weight loss, and its effect is more centrally. We are understanding that it's one of acting more on the central inhibitors and causing weight loss. And its effect is actually lasts for up to 10 years. There's studies that have suggested that maybe the weight loss effect of metformin is lasting up to 10 years. And it's a commonly used drug, so it's cheap. Definitely something to consider. Then liraglutide and like what they mentioned, Januvia, is a newer drug that you should consider. And understand that we can motivate for these drugs. You know, it's not like I think Januvia apparently you can get it because it's now on the guidelines. Liraglutide, if the patient has sleep apnea, the Medicaid's pay. Okay, so it's just understanding how your patient, does the patient require optimization of the diabetic medication, and these are all effective. They cause 5% and more, and now it's been about, most of them have been studied long enough for us to know whether they have serious side effects. The kerosene, as far as I'm aware, is not available in South Africa, but also very effective. And the other, buprenorphine, also available but quite expensive. And then topiramate, especially if you have an epileptic patient, it's a good consideration. Also still quite expensive. But the main thing is the expense is probably still holding us back, but there are ways in terms of motivating. Like I motivated for liraglutide or Victoza this week, actually, for a patient who had sleep apnea. So it is possible. So we must just make sure we think out of the box, get the reps involved, get them talking and saying, can we get this drug on board? And then there's always a way. It's important for us not to just say it's too expensive, give up quite easily, because most of these drugs, if we motivate and show that the patient will benefit, there's a way. So it's something interesting. In terms of bariatric surgery, I think Dr. Fayyoun will hopefully touch on it. But there is about 5 or 6 procedures, probably 3 procedures as far as I know, that are really being studied and shown quite effective. And bariatric surgery is extremely effective because the neurobehavior is not such a big deal as the other modalities, where the patient has to, you depend a lot on the patient doing, exercising, eating healthy. The surgery actually makes quite significant difference. So it's obviously a challenge, and you need to try the different modalities and motivate eventually for surgery. The other aspect I wanted to just touch on is that certain things, even if patients who've gone through bariatric surgery, there's still just slight improvement in the cardiovascular risk as well as sleep apnea and psychiatric conditions. So don't assume that just because your patient has lost weight from something like bariatric surgery, that those underlying conditions have resolved. So it's something just to keep in the back of our mind. This patient still might be struggling with these other underlying problems. So let's see if I kind of can explain the definition of obesity a little bit better. So obesity is defined as a chronic, relapsing, multifactorial neurobehavioral disease. So I hope you understand of the endogenous adaptations make us constantly it being a chronic and a relapsing disease because it takes our body to recover. Multifactorial we've talked about already, the environment, the sleep, the attention, all playing a role. Then the increase in body fat promotes tissue dysfunction and abnormal fat mass physical force. So the mechanical stress as well as the physiological effects that adipose tissue is causing. And resulting in metabolic problems that we more commonly see like diabetes, hypertension, biomechanical problems like reflux disease, osteoarthritis, and then the psychosocial problems that we commonly associate with this, like depression, anxiety. Any questions?
Did you say the arching increases your cortisol?
Yeah, so it's mostly on the granule.
Yeah, because stress also increases.
Yeah. So it's
a
more. There is an increase in cortisol. Cortisol, but usually with the dietary change, does suppress relatively. But the ghrelin is the problem. It stays persistently high even a year. The study was for about a year. So even at 1 year, it was still high. So cortisol was elevated up to 3 months or 6 months or something like that. I can't remember that's true. But the ghrelin stays up for a longer period than initially expected. You expect that these hormonal changes will happen quite quickly, but the adaptation is a very slow process.
What's your take on using beta ECG on the lecture? Beta ECG.
Beta ECG?
Yeah.
No, I'm not. I'll be lying if I know too much about it. But I think in terms of leptin resistance, is obviously also a hot topic, and obviously if your leptin is not working as well, then central inhibitors pathways is not going to work as well. I think the beta HCG and all are just trials and seeing if it will help. But it's more of an experimental thing that they're trying to see what might work. And I'm not convinced that they've actually really found something. If it was available, it would be on the market quite quickly. So I think they're experimenting with quite a few things and trying to see how they can improve weight loss, because it's obviously a growing problem.
And behavioral psychotherapy shouldn't be actually involved the psychiatrists and psychologists.
Yeah, I mean, I think we do need, you actually need intensive psychology and psychotherapy and counseling for these patients. Studies that have suggested weight loss from just behavior therapy is like 14 sessions in 6 months. It's not very practical, but it's intense counseling at times. And often our busy practices, we see the patients once, and then we see them 3 months or 6 months. And this is where now new evidence is coming on. What about technology coming into it? Can we connect with them as a webinar, or how do we use technology to make your The other aspect I would like to say, I'm not completely against technology, but one of the good things about technology is telling your patients to take photos of their meals, their cupboards, and then explain to them this, so that they become aware of what they're doing. Because they'll tell you, no, doctor, I'm eating healthy, and you tell them, no, I want a diary of your pictures, and please show me your pictures. What's your trolley looking like when you finish shopping and shopping? It's really, because then you will be able to educate them on their mistakes, and not just generalizing what they're doing. And it's amazing, this vitality, exercise, the iPhone watch. It's a brilliant idea because the effect of losing that watch pushes patients to exercise, because we don't want to lose something. And so there's some interesting, it's not just some gimmick that makes them come in. There is some evidence of maybe the loss of, losing the watch from not doing what they want you to do has a neurobehavioral change. So it is interesting how technology might also come and play a role in aspects like that.
Yeah, how many kilojoules does 70 kilogram normal white man consume a day?
Sure.
Then you get all these different diets. What does it mean?
Yeah, so it's usually just 500 kilojoules less, and that's more or less a rough estimate. But I'm not a kind of a dietitian, so I may not comment exactly.
You spoke about in terms of reprogram for not eating all the time. There's a lot being spoken now about intermittent fasting. It's not a diet, but it's a lifestyle.
Yeah.
Actually goes against the central teaching of breakfast is the most important.
Yeah.
It's that you eat at night and then you fast and you have a late breakfast around 11, 12 o'clock. And it puts in terms of you eat too much. And,
Yeah.
I think that's one of the advantages some of the studies show is your metabolism doesn't slow down. You do that where most diets you lose and then you plateau.
Yeah.
You actually put on weight even though you're keeping to the same calories and things.
Yeah. And I think, I don't know much about that, but it makes sense that probably our cortisol levels are peaking at early hours of the morning, and now you just maybe stimulating it a little more. It might be, definitely there might be some logic